everyone, I'm Dr. Lisa Medaglia, also known as Dr. Lullaby. Today we're going to talk about melatonin. I often get asked by parents whether they should be introducing melatonin as a solution for sleep problems. I'm going to review with you today what I tend to tell parents in clinic and when and how we use melatonin. So the most common use of melatonin is alongside behavioral intervention for patients who have comorbidities. The most common comorbidities where we're using this pairing of melatonin with behavioral intervention include patients with autism, patients with developmental delay, neurodevelopmental disorders, and sometimes severe ADHD. So these are cases where with behavioral intervention alone, we sometimes can't get the results that we want, and so sometimes we'll briefly introduce melatonin, sometimes eventually tapering off, other times sticking with it as an adjunct solution to behavioral interventions. When we're using melatonin like this, we typically will have parents try 1 to 3 milligrams 30 to 60 minutes before bedtime. I want to mention that there are two types of melatonin. The most common type of melatonin that you'll see at the drugstore or grocery store is an immediate release melatonin that lasts for only about 4 hours. So some of my parents will find on Amazon and other locations this extended release or slow release melatonin that lasts for a longer duration. That's particularly helpful for patients who have nighttime awakenings or early morning awakenings. So that's something to keep in mind. Another time when we typically use melatonin is when we're using it for phase shifting. So in our teenagers who have this natural tendency to want to go to bed late and sleep in late, sometimes we'll use a tiny little dose of melatonin 3 or 4 hours before the point where they naturally feel sleepy to slowly advance their circadian phase. It's a little bit tricky to do, but it can be really helpful. So it's a different use of melatonin and a controlled use of melatonin that we use alongside behavioral intervention, where we're slowly having these patients go to bed earlier and earlier and waking up earlier and earlier. If we're going to use phase shifting melatonin alongside behavioral intervention, we have to make sure our teens are not sleeping in on the weekends and not taking any naps. If we don't have a patient, if our patient doesn't have a comorbidity and we're not using melatonin for phase shifting and the child is otherwise healthy, then it's rare that we will suggest melatonin as a solution. I do sometimes still see parents and families that come in with their child taking melatonin, but oftentimes in those cases where we have a typically developed kiddo, we are finding that parents are very successful in being able to taper down on melatonin while introducing behavioral intervention. They're able to have their child successfully sleep on their own and have a more rapid length of time to fall asleep and return to sleep with less and less melatonin, eventually being off of the melatonin. So keep these things in mind when you're asking yourself this question or talking to your doctor about this question, and definitely keep your doctor close in the loop. Your pediatrician should be well versed with this concept of how and when to use melatonin, and make sure that that you consider this option of trying behavioral intervention alone and seeing if you're able to make gains that way. Thank you.